Okay, so these are my disclosures, and you can see it on the tab and down the road. And we'll start a little bit on the issues with prostate cancer, which we know all the research has been done and much talk about in the meeting today, so we're not going to pound on that. And the fact that the limited benefit that's been associated with treatments in terms of radiation and surgery with the 3 now randomized trials, but the bigger effect in quality of life, which have led to the growth of active surveillance, and the recommendations from the United States Task Force, from the screening studies that were nicely discussed this morning. And after that, I'm going to ask the first question. So please indicate how do you do your prostate biopsies: random transrectal, fusion transrectal, ambulatory hospital transperineal office, MR fusion transperineal. All right. So I'm an oddball here. So anyway, this is great information. Anyway, so we touch a little bit into the trials this morning as well. The 3 trials, including the PROTECT and the absence of survivable benefit. We saw some other questions. The most recent publication from Dr. Brawler and Dr. Witt in terms of the incidence and the benefits of prostatectomy versus observation. And it's interesting that in this series, 20% of men were eventually converted to surgery. When we look at the PROTECT trial, though, by 2 years, 20% of men had even been converted to surgery or radiation. And by the 10 years follow-up of that study, close to 70% of men had underwent a conversion. Okay, so and this is basically what we face in the clinic when we have our prostate cancer patient, or typical patient with a, let's say, intermediate risk and a PSA that is either clinical localized disease, and if they're potent and they're continent and they care about their quality of life, which they do a lot in Miami, it's a problem when you treat them in some of those things. They give and take, and the regret associated with it, as study by Dr. Eastman, among others, along with Mike Catan, shows that about 20% of men experience those regrets down the road. So here's the second question. A 67-year-old man with a PSA of 8.9, rectal exam of 50 cc's, a PIRATS-4 for a 10-millimeter lesion, had a fusion biopsy in 2 target areas, and had a Gleason 4+3, and that was in the left mid and close to the lateral area. It also has a Gleason 6 close to the central side of the prostate. It was a PRATS. And one of the cores detected was not detected by the MRI, and he has a shim score of 19 with normal ejaculation and IPSS, and a negative CT scan that was performed. So what would you recommend for that patient? Okay, there you go. You got a surgeon crowd here. Interesting that we got 13% who recommend some form of focal therapy, so that's more than what I expected. And the next question. In the last 12 months, have I conducted a transperineal or biopsy or treatment procedure? And I think with the answer was given in the first question, though. Okay, so about 30% in the hospital center and very few in the office setting. Okay, so we're going to talk about that and about the outcomes about doing MR-guided fusion cryoablation in the office setting, and trying to bring down the harm and keep the benefit that comes with screening of prostate cancer patients. So basically the current paradigm is that if you got an abnormal digital rectal exam or PSA, then you do a traditional biopsy, and then the patient is basically confronted to the decision whether he goes into active surveillance, depending on the characteristics of the tumor, or he undergoes treatment of the entire gland. On our fusion target paradigm, basically we do the same. We put some of our faith in the MR, and we also try to do more precision biopsy doing the transperineal, and then we can identify those lesions, and usually they're multifocal lesions, and then a plan can be adopted on the MRI setting and then fused to the prostate so the treatment can be undertaken. And then we continue to follow those patients. So it's kind of like trying to be in that gray area between doing a lot and basically trying to preserve their quality of life. So This is kind of what we do with bladder cancers. We don't take out the T1 high-grade disease. The first time we see it, we give them a shot, we resect them, we re-resect them, and we use BCG, and then we have learned over time which patients will respond better or not. Some of them may avoid a cystectomy down the road, some will not, but in the meantime, you don't pull the trigger right away. So that's kind of what we're looking for, and I wrote this protocol about 4 years ago, back in 2013, thinking about how could we undertake this, and to bring it up to current Gleason standards. Basically, the eligibility is stated there. If they have a Gleason score of 6 and less than 50% of the gland, and they're between 55 and 65, they're eligible. And if they have a 2 or 3 and less than 50% burden on a lobe, then the same thing. We kind of base that 50% on the MRI area of interest, and then we biopsy a lot that area. So the number of biopsies positive may not be the weight of doing it because you're oversampling the target areas. And the rest is in this slide. Coming from Memorial, understanding a lot about the variability that has to do with surgeons and other factors. One of the critical things that have to do is if any form of targeted therapy will to succeed is really the precision in the obtention of the images, the quality of the MRI images. Not all multi-parametric MRIs are the same, and also then on the processing and getting into a homogeneous environment where this can be reproducible and reliable may lead to consistent results, and that's what we're attempting. All the information tries to be captured from these patients in an app that's free for them, and so they have control, they know what's going on with their disease. In planning for this talk, since a lot of times people say, well, this is focal therapy or not, I wanted to put some definitions that this is what we use. So basically, focal therapy is when you use an ultrasound machine and then you decide to ablate some area of the prostate, whether it's a hockey stick, or it's it's a quarter of the gland, or it's the top of the gland. That's usually what's focal therapy in the literature. Hemiablation, when you take a lobe out, and whole gland in our definitions, when you take more of the 80% of the prostate. You could use fusion software or not, and we have done some of the treatments that we have done in the office, whole gland treatments. And then when we're talking about focal, or we're talking about targeted partial gland ablation, really is because we plan it on the MRI, and then we execute the plan. And in the office setting, and the ultrasound machine is nothing more than a good guide of where the areas of interest were in the MRI, and we can see it and treat it, and I'll show that in a little video. This is the typical plans that we have for treatment. As you can see, they could be, we are generous in the terms of the areas of interest. I think that a lot of this, the mishaps that happen with MRI that doesn't determine exactly the extent of the tumor, well discussed by Dr. Ryder and addressed as well by Nelson Stone today, shows that radiologists tend to kind of try to pin the center of that lesion, but they forget about the complete boundaries around it. So we tend to be generous on that, oversample a lot, and then eventually we go ahead and we plan the treatment with an area of margin. So we have 2 safety areas, and then the third one being the prostate itself. Again, this is the typical plan. Some tumors are anterior, some tumors are in one area, and sometimes we do a hemiablation if need be, or even a whole gland treatment. So for that, we use a lot of technological aspects, not only the freezing boxes or cryo machines, but we have used now multiple fusion platforms such as Artemis, MIM, and Coelis, and there's plus and minuses from all of them. But one of the things that is critical for the treatment that we do is really to have it be, can we start this? Okay, I can start it here. Is really to be able to monitor that and do real-time fusion. So I will play around with this for the interest of time, and basically one of the things we do is a block of periprostatic block that basically I designed roughly 3 years ago, and we have now tested in over 1,000 men over the last 3 to 4 years. Some of you here in the audience have seen this procedures live, and basically this is what allows to have this procedure done in the office setting. And and basically it's well tolerated by patients, and I'll show you some data. Then we use, when we started this back in 2013 and 2014, there were really two transperineal platforms of fusion software, being the BioJect system as well as the MIM system. So eventually we migrated to the MEM system because we thought it was more precise. And here's what it's showing is how we align the stepper. The patient is awake and basically chatting with us, and then we go ahead and do the card registration process in the transverse and sagittal views. And after the card registration is made, we will go ahead and execute the plan. So the guide for the treatment is going to be the MR. So there's the card registration complete, and here we can see it in the sagittal view. And right now we're going to go ahead and put the needles. You can see how the anterior needle is in place, and then we're going to go ahead and put the other needle and start the freezing process. Freezing and thawing process, 8 minutes and 10 minutes usually when we use the Galil system. If we use the EndoCare system, the times of freezing tends to be faster because the bore of the needle is a little bit thicker. And basically this is what's happening as we destroy the area of tumor. We don't use routinely warmers on these situations. We barely use thermocouplers nowadays. So this is not your conventional cryoablation. This is basically all guided by the MRI, and the extent of the ice ball is also seen by the fusion with the MRI. And that basically allows us to keep a perspective of the prostate as you go and freeze and thaw. The prostate tends to get to lose the image well in the ultrasound machine. These are other patients with other types of tumors, and you can see the patients are awake and they tolerate the procedure just fine. So I'm going to show you now some, I just want to go to the next slide. This is basically our progression since 2013, and we started doing cases as well in Spain, and most recently at Cornell with Dr. Hugh, who has been now doing this. This is the progression of cases since we started in 2013. So by the end of last year, we had 350 patients treated and 407 procedures done on them, about 92 patients in Madrid and 14 in New York. The first study that I did with this was to evaluate the pain scores using the FACES scales. We presented this a little while ago, and now we have it validated, so I think it's ready to be sent out. And basically, we realized that the pain associated that patients noted was mostly when the Foley is inserted, when the initial skin block is performed. But during the freezing and thawing process, there's really no pain at all, and they tolerate the procedure just fine. Now, we out of those 350 patients, we have treated 287 that met the criteria of fusion target ablation. The median time for those treatments is 58 minutes. And you can see on the right side of the slide, the pain scores that basically the patient had is basically the pain 1 or 2 that they experienced. The Gleason scores on this man, so roughly 46% of them have had a Gleason 6, yet the low-risk group is only 36%, 47% intermediate, 17% high risk, 70% of patients have T1C tumors, and the rest have been palpable. This slide shows characteristics of the treatments itself, the median and interquartile ranges, so usually it takes about an hour, the amount of pain that they may experience, the median volumes of the MRI. There's been about 46 cc's. The treatment area volume that we have measured when we treat, which is about 10 cc's, and also the number of seeds and rods that we use in combination to get there. Out of those 287 patients in our protocol, we mandate a biopsy, which is done transperineal after, and now this data is starting to mature, so now we have 151 out of the roughly out of the 287 patients, but there's 115 that we did last year that were not eligible. So So we're pretty good in the rebiopsy rate. And we can see that the positive just biopsies are done transperineal fusion afterwards. And we can see that the rates of positivity among the groups is quite consistent. We don't see any differences. What seems to start making a difference is how we did the biopsy before. If we did a transrectal biopsy, whether it was cognitive fusion or not, or versus transperineal, the actual yield of the transperineal biopsy is higher. So that means that we're not as precise designing these treatments when the biopsy is done in a transrectal fashion. This slide shows also the PSA response from roughly drops about 2/3 of the value from a median of 6.6 to 2.4. And this shows now with a median follow-up of over about 18 months that patients have the retreatment rate for this folks. So roughly 13% of men have been retreated. And this shows the actuarial analysis and the conversion rates which are there, which are very small. So as this data matures, we will have more to say about how the patterns are, but it's looking very promising. From the functional outcomes part, we now have seen that roughly 70% of men have improvements in their uroflows measured by uroflow before and after, and the figures on the right side just show an example of one, a medium drop in IPSS of 6. Also, we have that by 3 months, 72% of patients refer to have erections that are back to their baseline, and 77% refer they kept some ejaculation, some reported abnormal, some reported as decrease in amount. By 6 months, those numbers are 80 and 71% respectively. And this is basically where we are going now. So if you see what we're doing in our office, roughly 80% of our biopsies are now done transperineal. So we did 273 last year. And out of those, the yield of prostate cancer has been roughly 42%, but 72% of those cancers diagnosed have a Gleason 7 or greater, which I think goes a little bit what Dr. Lucia was talking this morning. And in the panels, you can see the typical planning of how we do this. We don't do it as meticulous, perhaps, as Dr. Crawford, as biopsy every 5 millimeters, but we look at the areas of interest, we target them, we make the bulky, and you can see why a transperineal biopsy will pick up some tumors that are not picked up routinely on just transrectal biopsy, especially that case on the right side of the slide. In addition to that, this is something very promising. We're working together. We've got close to 200 MRIs now and post-cryo patients, and we're starting to realize what is exactly the areas of what will represent the negative MRI after partial gland ablation, where we see that there's a shutdown really of their restriction, and there's minimal acquisition of contrast in that area that we treated. And this is typical how we obtain this MRI, and then we look at areas of interest. We will biopsy them. We'll do random biopsies transperineal, and we will biopsy the area that was treated in those 151 patients that I showed you before. So there's some limitations, of course, of what we're doing, and so far as single center data, but the data on the 2 centers is growing, and there's more interest around the country. We will be able to compare this ablation technique with others, with HIFU, et cetera. I think that cryo, the fact that we can do this safely in the office setting is a major advantage. It's critical that the variations are controlled, so have a standardized reading of these MRIs, et cetera. And follow the patients with the system that we have on an app. It's an office-based procedure. There's improvement in urinary function, as we discussed, preservation of prostate function. That means ejaculation, not only just erection, and the oncological results so far seem promising. So I want to thank everybody here. Dr. Crawford especially was with us a few years back, and anyone who visits Miami will take him to Dr. Crawford's favorite place over there. The entire people and mentors that I have throughout the years, including Dr. Eastman among them. And I will be happy to entertain any questions. Thank you very much.